Hello everyone. Welcome to our webinar, Healthcare and the Earth. Before we begin our webinar, we at the Medical Society Consortium on Climate and Health respectfully acknowledge that our advocacy, education, and learning across this country takes place on occupied and unceded land of many Native American tribes. To acknowledge this land is to recognize its long history and our place in that history. It's to recognize that these lands and waters and their significance for the people who lived and continue to live in this country, and whose practices and spiritualities were, are, and shall always be tied to the land and the water. Today's webinar is the second in a series for this year as part of our Climate and Health Equity Fellowship Program. The CHEF program, as we call it, is a program that recognizes the need for more diversity in climate and health leadership and a sharper focus on equitable climate solutions. The goal of the fellowship is to empower doctors of color from populations that face greater burdens from environmental effects and are underrepresented in medicine to become leaders in the climate and health equity, education, advocacy, and in policy solutions. I'm Dr. Mark Mitchell, the founder and director of the Climate and Health Equity Fellowship Program. Also joining me from the consortium to run this webinar are digital communications and state policy manager, Kimberly Williams, Beverly Harp, and our student intern, Clarissa Payton. They will be available through the chat to answer any technical questions during the webinar. Our other team members on the webinar are Dr. Venice Curry and Jordan Curry Carter. This webinar series is hosted by the Medical Society Consortium on Climate and Health and is held for 1 hour on the second Friday of each month from 3 to 4 p.m. Eastern. Today's webinar will be recorded and made available on our website for future viewing as part of our Equity Resources page on the consortium's website. Today, we are honored to have Dr. Jodi Sherman, founding director of the Yale Program on Climate, on Healthcare and Environmental Sustainability in the Yale Center for Climate Change and Health. Rather than using our time to provide further description of her impressive work, we're placing a link to her bio in the chat. As a healthcare provider, it's important that you consider the role that healthcare systems and providers play in regard to climate and health. In this webinar, Dr. Sherman will talk about the environmental impacts of the healthcare system and its effects on public health, and what healthcare providers can do to help them mitigate their impact. The general format for today's webinar will be a 30-minute presentation by our speaker, followed by 15 minutes of questions and answers from our audience. We will ask that you put your comments and questions and any resources that you may recommend into the chat box at any time during this presentation. We'll get to as many of these questions as we can during the question and answer period. Please keep yourself muted so we're not interrupted by background noise. Jodi, you may go ahead and begin.
Well, thank you, Dr. Mitchell, and to the Medical Society Consortium on Climate Change and Health for this honor, this great opportunity to be able to present to your fellows today. And I'm really just delighted by this opportunity. Can you see my screen okay? Great.
Yes.
Thank you. So really, as did probably most everyone here who is driven by this topic, my journey came through my practice as a physician or as a clinician, and really just being delighted by the privilege of being able to take care of patients and help them in their journey towards health. I am a practicing anesthesiologist. But during my training, it was just so very disturbing to see how much stuff we're using, how much stuff we're throwing away, understanding that it must be causing some harm to public health and having no guidance on how to do a better job. And I actually made a pact with myself as a resident that I would not continue to practice unless I tried to make a difference. And so it's really about moving beyond this question of what's best practice for our patients to what's also best practice for public health as we take care of our patients. And so today's learning objectives, I hope people can take away that there is a relationship between healthcare pollution and disease burden, to be able to define what life cycle assessment or analysis is, summarize some of the high-level latest healthcare pollution findings, and to identify some opportunities for mitigation and personal practice, leadership, and advocacy. So why sustainability in healthcare? A lot of this you already know. Pollution is a leading cause of morbidity and mortality globally, responsible for 9 million deaths annually. Healthcare itself is a leading emitter of environmental pollutants against our mission to first do no harm. And reducing healthcare pollution can improve the triple bottom line, the best care for the most patients at the least cost. We'll revisit what we mean by that. And then part of what engages me is that engaging healthcare professions, not every healthcare professional, even though they may care about pollution, they may care about climate change, they may not make it a priority to be an active leader in this. But if you get them involved in their personal practice, I think that's how we engage health professionals and really have a key moment to lead in this transition to a sustainable economy. So engaging health professionals is key to public policy and societal transformation. It's part of what motivates me. And so most of this talk will be about climate change and carbon emissions stemming from healthcare. Obviously, that's not the only type of pollution of concern. So if you're familiar with the work of Stefan and Whitney, looking at the planetary boundaries or those systems within the ecosphere that support life on this planet. So red meaning we're out of bounds, gray meaning we're actually in a gray zone. We don't know if we're within bounds, without a bounds, in terms of the planet's ability to sustain life. So, for example, we recognize we're in the midst of the 6th great mass extinction. Our ocean is becoming more acidified. It's the greatest fastest carbon sink. So this is tightly related to climate change, land overuse. All these things are related. So we don't want to be outside the boundaries of the planet's ability to sustain life. Now, we can reduce pollution, we can reduce healthcare pollution by providing less care. That's not the solution. So we don't want to fall short. And so the work of Kate Rayworth, who's an economist, coined the phrase donut economics, that you don't want to fall short on our duty to protect and support health and well-being and fair livable wages, clean air, and so forth. So we don't want to fall short on our social foundation. So the sweet spot between the ecological ceiling and the social foundation is called the donut, and that's really what we need to aim for. And so even though this talk is mostly about climate change, I will give a couple of mention of some other things, including novel chemicals. I never used to think about this as a healthcare provider, but the healthcare sector is a leading purchaser of chemicals globally. There's more than 100,000 industrial chemicals in existence. Unlike pharmaceuticals, there's historically been no requirement to prove safety before introducing them into the marketplace. And so just like the tobacco story, it used to be that you have to prove a connection of ill health related to chemicals and then try and get them removed afterwards. There is a movement towards precautionary principle, which is to, just like pharmaceuticals, put the burden of proof of safety before they get introduced. But the cat is really out of the bag on so many of these chemicals. And I was really introduced to this through the Environmental Working Group. One of their landmark studies, the body burden study, was a small sampling of newborn cord blood across the United States, looking for something like 267 chemicals of concern out of that 100,000 or so. And virtually every sample had all of those chemicals in it. So essentially, they showed that babies are being born polluted. That's pretty powerful. That we didn't consent to be part of this mass experiment. There's no part of the planet that is not contaminated by chemicals. Pharmaceuticals, it's a similar story. Pharmaceutical contamination is ubiquitous. And because the doses are so small, they're not pharmaceutically active as intended. That doesn't mean that they're not wreaking havoc. And this is a big area of concern now. So I'm going to shift our attention back to climate change, and I'm sure you're all aware that the sixth report of the Intergovernmental Panel on Climate Change just came out, and the story hasn't changed. This is specifically from the special report in 2018, and this graph here is from the climate tracker. So, business as usual projections for emissions and warming, our current policies, our pledges that stem from the Paris Accord, and then what we need to get to limit warming to 2 degrees. And what's really being advocated for is trying to limit warming to 1.5 degrees to avert the worst predicted harms to civilization before the end of the century. We've already seen, this slide is already dated, it's hard to keep up. We've already seen an average surface temperature warming of 1.1 degrees centigrade. That's average. Of course, it varies where on the planet and the date and the time and the season. We've seen changes from 40 to 7 degrees centigrade on either pole. So this may not seem like a lot, but we all know that it is. And we are likely to reach 1.5 degrees by mid-century if we don't improve our behavior. And so the recommendation varies somewhat slightly, but bottom line is we essentially have to have our emissions by 2030 and reach net zero emissions by 2100 to avert those disasters. This is possible when the laws of physics and chemistry, there's no new technology. It really is about political will. And so this group is all expert in this, that nobody's diagnosis, nobody's death certificate is going to say climate change. Climate change exacerbates existing health threats, introduces some new ones. And we know, of course, that climate change disproportionately impacts those populations that are most vulnerable, and exacerbates the underlying social determinants of health. And so other ways that climate change impacts the delivery of healthcare, in addition to increasing demands for health services, climate change also disrupts our ability to deliver healthcare services. We can't even keep up with these stories anymore, but these are ones that touch me personally because I have roots both in California and the New York, Connecticut tri-state area. Hurricane Sandy, you're seeing famous images on the left of the evacuation of Langone Medical Center. And on the right, you're seeing patients, evacuated from the Paradise fires. The hospital on the right was devastated, caught fire within an hour of evacuation. So these are becoming more and more common events. And so they're disrupting our ability to deliver care. And of course, we are familiar with Hurricane Maria, which devastated the island of Puerto Rico, where so many of our medications and saline fluids were manufactured, and often the only source of manufacturing supplying the entire United States. The public is really quite familiar with that we had saline shortages, but we had lots of medication shortages as well. Myself as an anesthesiologist, we have spinal grade bupivacaine, a local anesthetic that we use to do spinal anesthetics for emergency cesarean sections, among other types of care. And these 2 ml vials ran out. So we had to substitute 30 ml vials. And because of concerns for cross-contamination regulations, we essentially had to throw out 95% of the vial. Or we had to really cut corners to try and do so without protocols in place. It becomes very dangerous. But we were pretty much in this perverse situation. At the same time we were on shortage, we were increasing our waste. And so that's about how climate change and pollution, a little bit about how that impacts healthcare. But now how does healthcare impact climate change? Now, healthcare is an enormously consumptive industry. In the US, 4.1 trillion or 20% of our economy just goes to healthcare. And as we know, hospitals in particular run 24/7 high-tech with high-tech diagnostic and therapeutic equipment. And we have this unique thing in our industry around infection prevention, risks and regulatory requirements that, there's no other industry that compares, maybe a little bit in the food industry, but really nothing that compares to healthcare. We suffer from, both to protect us, but also contributing to the problem, regulatory complexity and business models driving wasteful, unnecessary utilization of resources. We also live in a very wealthy nation. There's this culture of excess where disposability is normalized, where it's become normal to open things you may not need just in case, throw away simple things from blood pressure cuffs to pulse oximetry probes, to pillows and bed linens, to complex surgical instruments after a single use. It's really quite crazy. We get a pass because we have a social mission in healthcare, right? We do good in the world, we take care of patients, we feel good, but what about our duty to public health, to community health? And that has been ignored historically, and this can no longer be ignored. And so our work with the Lancet Climate Change and Health, we contribute to the annual report metric 3.6, which is tracking international healthcare performance. Globally, healthcare emits nearly 5% total global greenhouse gas emissions. So on the x-axis is per capita healthcare spend. On the y-axis are associated greenhouse gas emissions per healthcare dollars. And so this is an enormous industry. So I said in the US it's 20%. Globally, healthcare is 10% of our global economy. And it's rising as nations are developing, as the population is aging, as pollution and climate change are worsening. The demands for health services are only going to grow. A quarter of these emissions, so we're an outlier in the US, not in a good way, a quarter of global emissions stem just from the US, even though we're only 4% of the global population. And emissions are rising between 5 and 6% annually. So now if we have the best healthcare system in the world, there might be some argument that we get a pass until those drivers of emissions are addressed. But as we know, we don't have the best healthcare system in the world. Sorry, hang on a second, I apologize, sorry. So this is looking at greenhouse gas emissions from the healthcare sector per nation. And we associated that with the Healthcare Access and Quality Index of the Institute for Healthcare Metrics to try and get at some measure of health system performance. This is from the 2019 Lancet Countdown Report. In 2020, we did the same thing with the Human Development Index, and stay tuned for this year, but the story is the same, that there are nations that perform better in terms of healthcare access and quality with much lower emissions than the United States. In fact, so we're at about 1,700 kilograms of CO2 per capita. The break-even point was around 400, 450. So the good news is there's opportunity to reduce emissions without sacrificing quality and access, and in fact, opportunity to even improve that. And as we know, about 1/3 of healthcare services in the US are deemed low value or inappropriate. It's 1/4 globally. It's a problem in high and low income nations, but we know we have a problem here in the US. We also know that 11% of our population is uninsured. If we shifted those monies and natural resources toward taking care of more patients and better care, we could achieve a better health system. And so this is to show that that healthcare is causing harm to public health, we can actually estimate how much that harm is. And so we did just that. And if you look at both greenhouse gas and non-greenhouse gas pollution, so again, this is mostly about carbon emissions, but not exclusively. So if, fossil fuel consumption produces not only greenhouse gases, but also toxic air emissions. And so air pollution is especially the problem here. That if you put it all together, the US healthcare sector, which is about 8.5% of our nation's greenhouse gas emissions, similar fractions of toxic air emissions, that disease burden combined is around 388,000 disability adjusted life years lost annually. And why you're seeing this is that, if we go back in time to the To Air is Human famous report of the Institute of Medicine, now National Academy of Medicine, this was a groundbreaking work. We thought we were doing safe care, good care before this publication came out. And what it did is it shined some light on the fact that medical errors are a huge problem, and preventable medical errors result in then an estimated 44 to 98,000 deaths annually. And the actuaries tell us that it's about 10 years of life lost. So if you multiply by 10, you see we're pretty much in the same order of magnitude of harm. There are different measures, so we can't do a direct comparison, but basically we're in the same order of magnitude of harm. And this is important because this report sparked the whole patient safety movement, that everything we do now in healthcare is through the lens of patient safety. And if we acknowledge the fact that indirect harm from healthcare pollution is on the same order of magnitude as from medical errors, we can confidently say that pollution prevention ought to be the new patient safety movement. And so to be able to address these emissions, we have to know where they're coming from. So relatively speaking, and this is from the UK, if you know, there's a similar story at those healthcare organizations and nations. There are several national studies. The story is pretty much the same. About 70 to 80% of emissions come from the supply chain. 20 or so percent of emissions come from things like fuel consumption on site and purchase electricity. So the operations side of healthcare delivery. So 70 to 80% from the supply chain, most notably pharmaceuticals and chemicals, medical devices and supplies, and food. And clinicians, so you and me, also administrators, regulators, we control the consumption side of things and the waste or inappropriate care. So this is to help us understand the levers. Manufacturers and regulators, they control what's embedded in the stuff that we use, what goes to marketplace, so our direct and indirect levers of action. So we're going to come back to this issue of healthcare-acquired infection because so much of what we do in the name of patient safety is centered around prevention of healthcare-acquired infections. And it's really important to do so. It's the most frequent adverse event in healthcare delivery worldwide, hundreds of millions of patients affected, and it costs our health systems a lot of money in the US, billions of dollars. And it is our duty to prevent harm. It is our duty to prevent infections. Obviously, we're not going to not throw things away because we don't want to cause harm to the environment. Our duty is to the patient in front of us. Unfortunately, what's happening is that there's this non-evidence-based trend of everything becoming single-use disposable. And we really need to, and some things do need to be disposable, some things that are difficult to clean, cheap to make, small IV tubing catheters as examples. Obviously, we're not going to clean and reuse those, but there is an unscientific trend toward disposability, and we really need to, it's really quite alarming. Now, if we look back at, just as an example, one type of infection, surgical site infections, if you go back in history, it used to be that, as an example, around 1800, if you had a major surgery like a limb amputation, you had about a 95% chance of being infected and about a 40% chance of survival. So this is a survival curve. This is the infection curve. Then along came my hero, probably one of yours as well, Semmelweis, who deduced germ theory, and then Pasteur and Lister, who not, and Leeuwenhoek, of course, who made it possible to prove that Semmelweis was right, and then Lister, in terms of aseptic and antiseptic techniques. And that was the most important thing in the history of medicine in terms of preventing infection. And then between around World War I and World War II, you see another decrement here, a blip in a decrement, and that was the introduction of antibiotics, antibiosis. And you can see we're steadily approaching towards zero here. So zero, less than a 5% chance of getting infection, greater than a 95% chance of survival. So, and if you blow that curve up, you see we're asymptotically approaching zero in terms of trying to reduce our risk of infection, but we're throwing more and more stuff at this problem, trying to get to zero infections and ignoring this indirect harm on public health through unnecessarily over-cleaning and consuming disposable devices. and materials and even our pharmaceuticals. So we really need to find this balance. But right now we're way out of balance. We're trying to get to zero. There's all these zero harm campaigns, which are really quite laudable in intention, but are causing that's shifting the burden and harm elsewhere. And we really need to shine a light on that. So because it's not feasible. And in fact, part of the challenge in infection control is that the cause is multifactorial. And one of the biggest contributors is staff hygiene, hand washing. Embarrassingly, we still don't do enough of that. Proper cleaning and draping. So our aseptic and antiseptic practices. Patient health status as well. We've got a sick population, a lot of patients that are immunocompromised, so diabetes, cancer, autoimmune diseases. Obviously, other things that contribute to infection, the exposure site, the type of organism, and the size of inoculation, and so forth. But really, we know that the two most important contributors to try and prevent healthcare-acquired infections are hand washing and boosting host health status. And those are problems we cannot solve by throwing more and more devices and consumables at the problem. And just to briefly touch base on things that are not climate change specifically, plastic, which by the way is derived from fossil fuel, is a growing problem, as we're all aware. You're probably aware of the big garbage patches on the ocean. It's not just on the surface of the ocean, so it's nice that there's some equipment that's been designed to clean this up, but it's also the bottom of the ocean. So this is just talking about macroplastic, and so the World Economic Forum has done a report that showed that business as usual, there will be more volume of plastic than fish in the ocean by 2050 if we don't change our ways. And of course, it's not just the macroplastic, it's a microplastic, and I can't even keep up with these studies. So plastic fiber around the world is found in tap water. Microplastics found in human stools is actually found in wild animal stools in remote locations. This is just from about a week ago. Microplastic found in human blood, and just yesterday, microplastic found in lungs of patients undergoing surgery. They looked at for some tissue, and we don't know the havoc that all this is wreaking. But chemicals plastics are laden in chemicals. So phthalates is a class of chemicals that imparts desirable characteristics like flexibility. A lot of the supplies that we use in healthcare are laden with phthalates. So there's a movement to make our equipment phthalate free because they are known, the class of chemicals are known endocrine disruptors. The problem is that we don't really know what's being substituted because of the way of our regulations are structured. So, trying to make things phthalate free may be a red herring. And so, there's a lot of similarities between the COVID pandemic and climate change, and that we've been so dependent on single-use disposable devices. Really just caught with our pants down in terms of disruption to production, disruption to transportation, and things we never thought would happen in a high-income nation. On the left are this is a group of nurses in a hospital in New York City. On the right, this is a hospital in the UK, and those of us in the trenches are really quite familiar of reusing. Not only innovating, but reusing things that were not designed to be reused. And while PPE made the headlines, it wasn't just PPE. Capital equipment like ventilators, laryngoscopes, which affected me as an anesthesiologist, drugs for sedation, dialysis supplies. So really what we have is a global supply chain that we are, and just-in-time delivery. Globalization can certainly reduce production and storage costs and our local pollution, but really in some countries, but it also increases pollution elsewhere. And we know that there are issues with fair labor practices elsewhere in the world. So there's a real question of if this is a just system, this lack of transparency. So lack of transparency to risks for climate change and pandemics, and lack of transparency for fair labor practices. In the UK, they do have very strong laws requiring that fair labor practices be demonstrated 3 tiers into the supply chain. To be honest, I don't know how that's enforced, but the intention is certainly there. But we really have to ask the question of, what is a disposable medical device? And just because something is labeled disposable, this is very important, just because something is labeled disposable does not mean it can't be reused. This is an industry designation, and what it means is that whomever cleans a single-use device is then responsible for its function as if it's new. And this was, intentional by industry to try and manufacture obsolescence. And, institutions don't want that responsibility, so they started throwing things away. Now, there is a whole industry called reprocessing. What does reprocessing mean? Technically, it means cleaning a device, whether you're doing it in your hospital or it's being done by a third party. So this industry of reprocessing tends to refer to third-party cleaning of those disposable devices. Industry pushed back and said that's not safe. Well, the Congress commissioned a report in 2008 from the Government Accountability Office that said, there is no increased risk from third-party reprocessing versus new devices. And but unfortunately, reprocessing single-use disposables is not taken advantage enough. Only 2 to 3% of those devices that are reprocessable are done so. So if we look back to the pandemic, again, now we have the option to use reusable things. There are reusable masks and gowns, and in the case of my profession, laryngoscope blades. But we didn't have them. Certainly during the surge, there wasn't enough availability of reusable ones. So we had no choice but to reuse single-use disposable devices, including PPE. And while there is a third-party reprocessing infrastructure that is heavily regulated, it takes time to develop safe practices that did not exist for these devices. So we were extending use. We had to figure out how to reprocess them ourselves under the Emergency Use Act. And you know what? We figured out how to do it safely. But this really begs a question. If we figure out if we can reuse these things safely, then it begs the question, what's the difference between a reusable and a disposable device? And certainly durability is one issue. So really what we have is a linear economy, meaning that we think it's normal to extract resources, make something, use it, and toss it in the trash. That's not how nature works, right? Nature has closed systems. So the concept of the circular economy is to keep things in use at their highest functionality as long as possible, and to refurbish and repair things as needed. When things can no longer be used for their intended use, you can repurpose them, their materials. And recycling is also part of this, but it's the last thing that you want to do. And really, we need to move upstream and redesign. And this isn't just medical devices. This concept of the circular economy also applies to pharmaceuticals. And we really have to address policy drivers that are really pushing us toward this manufacturing obsolescence. So let's talk, briefly about greenwashing, the practice of making unwarranted and exaggerated claims of sustainability or environmental preference in an attempt to gain market share. So I find this interesting that GreenBiz calls recycling the greatest example of greenwashing. We spend so much time in healthcare and also in our personal lives, but get so worried about recycling things because we're so distraught and upset by all the things that we're throwing away. But it really is a distraction that we really have to prevent so much waste to begin with. So life cycle assessment is a engineering modeling tool to quantify emissions. We tend to think things while we use them. We think less about what goes into manufacturing and packaging, even less about that natural resource extraction that supports it all. And maybe we think a little bit about what happens when we toss things away. But you have to consider the entire life cycle to be able to inform decisions. And the drivers and the problems are not always intuitive. And even again, we're talking mostly about climate change. It's not the only impact of concern, and we have to be careful when we're not shifting one problem area to another as we solve one. And so this is what we use to inform design and decision. decisions. Just a very brief example of one device from my own profession, the laryngoscope. On the left, you see a reusable handle and blade. On the right, a disposable version. These were, this is just an example of thousands of devices out there that there's a now push to go towards single-use disposable. There is no justification from the infection control perspective. We have policies in place that are safe to reuse, but nonetheless, moving in that direction. We did an LCA comparing reusable and disposable laryngoscopes. So that means looking at one disposable from raw material extraction to use in solid waste management, and compare that to how many reuses you get out of the reusable device. In this case, it was rated for 4,000 uses. So you add up all the energy and the materials that go into that. So one manufacturing plus 4,000 uses, cleaning, repackaging, and one disposal, including refurbishment. So if you compare them, we also did a cost analysis, including looking at refurbishing and labor. And there's a lot of information here, but if you just squint at it, if you look at the gray, those are disposables, plastic and steel disposable versions, and the gray are the reusable versions. So that's one takeaway here, that several times more emissions come from going the disposable route, just this one device. And well, we can recycle these things, and so people feel it's okay to toss them. So our study looked at the average waste mix in the US, which is a fraction of recycling, a fraction incineration, a fraction of landfilling. That's what the red is. That's the waste phase of the entire life cycle emissions of these devices. If we could 100% recycle these devices, and we cannot, it's not possible, but just as for the sake of showing, the bar here is what if we could 100% recycle. So this is just to demonstrate we cannot recycle our way out of this problem. And sorry, so this is just a cost analysis of my own institution. The takeaway here, again, just squint at it, the gray is a disposable. Just my own department, about $750,000 more in annual cost by going the disposable route. Now we reprocess about 12,000 instruments a day. This would add about another 167 because we already reprocess, one portion of the device. And so we would not have to add labor to be able to do this, which is a common criticism. But even if we did, we could support, more employees in the local community and still save the institution money. Now, I also want to point out that it matters where this study is done. We use the average energy mix in the US. If you did the same study in Europe, the reusables would look far more favorable because they have cleaner energy. So the reprocessing portion, we all buy our stuff from the same global resources, but the cleaning is the big deal here. So reusables would look even more favorable in Europe. If you went to Australia or China, where they're heavily dependent on brown coal, in fact, the reusables look slightly worse than the disposables in those nations. So does that mean that those nations should use disposable? No, it means that they need to shift to cleaner energy, which we of course need to do in the US and globally. So, when we look toward what our aspiration is, of course, we look to the UN Sustainable Development Goals, which is about well-being and thriving, universal healthcare, and so forth. But really, we need to tie this to the future of what healthcare sustainability looks like. So this has been a lot about emissions and climate change emissions in particular. But, when we talk about how we avoid greenwashing, we need to measure our emissions, and not just our pollution emissions, but our social performance, our governance structures for accountability. There are standard metrics for accounting for these things in an organization, and there must be transparency, and there must be third-party accounting assurances. So this whole ESG framework movement is really based on the financial accounting structures. And there must be some endpoints to goals, so science-based targets and timelines. So all these objectives must be aligned with the US US SDGs, excuse me. Presently in the US, ESG accounting, which is really quite prominent in industry and hardly existent in healthcare organizations. This is presently voluntary. You know, the movement is quite strong in industry because there are a lot of consumers asking for it. There are risks to be averted, and the business case really shows that this is the way of the future. But it's presently voluntary. And if you've been following the news at all, the SEC proposed some climate mitigation rules, which really would make this mandatory. And this will actually impact healthcare organizations, all publicly traded organizations. And this will have repercussions even for non-publicly traded healthcare organizations. So we really need to learn and do more about that. These are just some selected metrics. I really turn you to a recent article led by Dr. Emily Sine in the New England Journal of Medicine Catalyst that show how we can measure these things on the environmental dimension, the social dimension, including diversity, equity, and inclusion, safety and well-being, human rights and labor standards, and then governance, including good corporate behavior and good behavior of our executive leadership. So there are a bunch of metrics proposed here that do tie to the SDGs, and I encourage you to take a deeper dive into that paper. So what's happening in healthcare now? We're finally at the end of the talk here, so thanks for bearing with me. There's a whole movement for healthcare systems nationally to commit to get to net zero. Really the greatest leading health system in the world is out of the UK. They have committed to get to net zero. They're the third largest employer in the world, or maybe it's fifth, but somewhere in there, after the US military and the Chinese military. So a huge organization. They've been measuring their health system emissions for well over a decade now. And why that matters is because if you want to figure out as an organization how you're going to get to net zero, you need to know where you're starting from, where those emissions are coming from, what your potential interventions are, so you can figure out how to get there. We need to strategically measure and manage our emissions. They have committed to get to 40% reduction by 2030, that's 7.5 years from now, and to get to net zero by 2040 without their supply chain, 2045 through with their supply chain, through clever and mandatory contracting schemes, and this is the aspiration, and really the goal is to get to net zero as quickly as possible. This needs to happen at all of our organizations, healthcare around the world. You know, at COP26, something like 54 nations committed to get their nation's health sectors to net zero. That's a really fantastic initiative. Unfortunately, most of those who that committed are low-income nations who are contributing the least to this issue and have to struggle to figure out how to provide greater access to care and safer care, and really have justification for increasing their emissions rather than reducing their emissions. And most of those who've committed don't even have a plan of how to get there. So we've got a lot of work to do. We have proposed as clinicians, how to be active as clinicians, a planetary healthcare framework to get to net zero. This framework, you've heard a lot of this, and some of this is unsaid, which is why I'll say it, that we need to reduce the emissions embodied in healthcare services. We need to move to electrification away from burning fossil fuels, but that electrification needs to be based on clean energy. We need to move to a circular economy and be good stewards of our resources and not wasting things. We need to match supply with demand. That means we have to avoid inappropriate low value care, which means both too much and too little, but we've got a big problem on both ends, but particularly in too much care, which is preventing us from providing care for everyone. And we need to, what we haven't talked about is moving upstream, and that's reducing the demand for healthcare to begin with through health promotion, disease prevention, addressing the social determinants of health. And we talk about the triple bottom line, the most care for the least cost, the best care, the most care at the least cost. This is how we maximize value, but we also have to minimize our environmental and social harms as well. And I'm going to pause there and thank you for the opportunity to speak today.
Thanks so much, Dr. Sherman. I had a hard time finding my unmute button. So we're going to take questions from the audience now. I remind you that you can type your questions into the chat box, and then we'll get to as many of them as we can. But I do want to ask you to take a moment to fill out our webinar survey. The link is now in the chat box. So I will take the prerogative of asking the first questions, and then I will go to Jordan for a follow-up question. So, and that is, as a clinician, where do you start with something like this? What can one health professional do?
Yeah, that's a great question. And I see Dr. Slutzman is helping out by placing some links in the chat. But, one of the papers that we recently published in the British Medical Journal was just that. And that is, what clinicians can do. And it's on every level, including the micro or the individual level, from our personal practice and how we choose to model good, sustainable practices, to getting involved in our own healthcare organizations to help them be good corporate citizens, and getting involved on a macro level with our professional societies and public policy to help address those barriers that are driving us in this direction. I only touch, in such a short talk, I can only touch on some of them, but there are things we can do at every single level, and no matter who we are and what our aspirations are. Now, of course, all of the fellows in this group here are really powerful advocates, but not everybody is going to be that. But we can engage everyone, even on their individual practice, because you have to have your head in the sand to not, on the individual level, understand that there's a problem and that there's a duty and we can do better.
So how do you get your institution involved if you are hospital-based practitioner?
Yeah, it could be a clinic, it could be, a community-based organization. The story is the same, and that is, really taking talks like this to educate the leaders in that organization. That's a really important place to start, that they need to make goals to make the organizations more sustainable. And, we all start from zero. Like, I didn't learn any of this in medical school. This is a journey of self-education. And so we need to educate ourselves. We need to educate our organizations, administrators. But I will tell you that, just coming from the perspective of the hospitals, a lot of this work starts with clinical recycling, and to be quite honest, a lot of it's coming, from nursing. Nursing staff. This is really fantastic. That there are all these people who see the problem and who want to make a difference and don't know what else to do. But clinical recycling is an area that people that usually get started in an organization. It's the most obvious and something that we feel badly about. But part of what I pointed out to you is that, I think, recycling I almost think recycling should go away because it's a distraction from doing, higher impact work. But the point is that those organizations who move much more quickly toward becoming better corporate citizens are those where it's mission driven. It comes from the top down. And so it really is about engaging your leadership. And you can't do it without engaging your staff. So it's bottom up and top down, but it can't be, as I say, it can't be a merry band of volunteers in some silo. It has to be integrated throughout all operations of an organization. So that means engaging leadership. And that means starting out, as all of us are, by getting in the room in our C-suite and giving this type of talk.
Great, thank you. Jordan, can we have the first question for Jodi?
Sure. Thank you, Jodi, for this presentation. And the first question we have, it really starts with this comment. Surgeons are afraid of infections, both because of harm to patients, but also because of getting sued. Is the way around this defining science-based standards of care that hit that risk-benefit sweet spot that includes environmental goals?
That's a really great question. I would say not just surgeons. I think every one of us is very concerned about infection. But yes, obviously, when you're intentionally causing wounds and going into cavities that are meant to be sterile. It's much higher risk. But I would say that I'm not sure, we have to really educate ourselves and educate our infection control specialists within our institutions about not going all out where the default assumption is that disposable is better. If you really dig into the literature, so I had to do that in the case of just one example, the laryngoscope. I had to be familiar with every single thing ever published on infection transmission. And there have been infections that have been transmitted through laryngoscopes. However, we've changed our policies and requirements around cleaning. And since the most recent iteration, and I forget now what year it was, it hasn't been an issue. So it really has to be about looking at the evidence and not just assuming disposable is better. And by the way, infection can be transmitted through the disposable devices if they're not handled properly. So it can't just be a default assumption. But part of the challenge organizations face are regulatory requirements, are oversight bodies like the Joint Commission, and other types of oversight bodies, or even the mock oversight bodies who come in and say, who well-intentioned basically are saying things need to be disposable when that's not necessarily the case. Or, and also industry like jumping on the opportunity for regulatory gaps, through their published instructions for use, which describes how to use devices, but also how to safely clean them. So basically, industry is up-classifying the infection risk of the devices to require more cleaning or making cleaning practices more and more challenging. So organizations are being faced with all sorts of reasons to throw things away. It's enormously complicated. Fear of infection is one of them, so we have to really be rational. In the case of the laryngoscope, it's going in your mouth is dirty, you go to restaurants and reuse silverware all the time. So, let's be realistic and rational about these things. We could have a whole talk on infection risk, but it's enormously complicated. Fear of infection is just one of them, but we have to educate ourselves on the literature as well as address all these other drivers.
Thank you. Jordan, can we have the next question?
Next one is, has anyone ever looked at incineration of propofol and its impacts on climate change?
So it's a great question. So we did a life cycle assessment comparing inhaled anesthetics and propofol. These are different types of general anesthetics. Propofol is an intravenous drug. And it really became a very important paper because it, among other things, it showed that the life cycle emissions of inhaled drugs are about 4 orders of magnitude greater than the intravenous alternative, just looking at the active ingredient. Now, that study essentially assumed that propofol is incinerated, which is how the manufacturer intends its waste to be handled. We incinerate our pharmaceutical waste, and that's basically what we modeled in that study. The challenge is if things, that there are leaks around manufacturing facilities, things are not disposed of properly. So some of that drug actually gets its way into the environment, as well as metabolites after they're excreted from the body. And our municipal sewage systems are not designed to treat pharmaceuticals. So there's also this question about non-greenhouse gas pollution. But I will say, we did model incineration, and that is, how it is, and the vast majority is treated.
Great. So why don't we take one last question?
Sure. This next one, what suggestions do you have for controlling microplastic in humans?
Wow. We have to stop using so much single disposable stuff. We have to redesign things and make them reusable. We have to normalize and slow down and have more reusable things. And our medical devices need to be modularly designed. There's a whole business model called servitization, where rather than buying products and the business model is on consumption and the business incentive is on consumption, servitization is buying the service the function of a device rather than the device itself. And so industry retains ownership. And so they are incentivized for durability and reuse and the circular economy. We also have to, do our own part. It's so simple to buy a cup of coffee and a to-go mug and toss it mindlessly. We have to, in our personal lives, move toward more reusable things as well. Now, there are a lot of regulatory barriers, production pressures, a lot of logistical issues, but we have to do this for our future, for you, for our children. So I don't have an easy answer on how we prevent microplastics, and getting in pollution in our bodies, other than, stop putting plastic in the environment.
And if I may add, plastics are made of petroleum products, but they can also be made from compostable materials, from plant matter, polylactic acid. But we need to move the economy toward the safer alternatives. And we can do that. The price is higher at the beginning, but as we do it more, the price will drop, as it does with a lot of technologies. I know that this discussion can go on for much longer, but we really need to wrap up this session. So I'd like to thank all of you for participating in our webinar series, and would like to thank our speaker, Dr. Jodi Sherman, and I hope that you found it useful. So these webinars are held the second Friday of the month. The next webinar will be May 13th, and the topic will be extreme heat. But before you leave, we remind you to take a moment to complete the webinar survey if you haven't already. Again, the link is in the chat. We'd like to thank our supporters for this webinar. This webinar series is made possible by generous support from the Johnson & Johnson and the Energy Foundation and the American College of Physicians. So this now concludes our session. So have a great day, everyone.